Okay, so my name is Jimmy Chirumira, as you can see me, and I'm going to be taking you through pediatric nursing 2. Yeah, so as you can see before you, the presentation, the course outline is basically there. And what are we going to cover in pediatric nursing 2? Basically, in pediatric nursing 2, we are going to be covering quite a number of things. As you can see, we shall talk about the immune, the immune stroke hematologic system, where we shall talk about things like anemia. We shall talk about sickle cell disease. We shall talk about DIC. We shall also talk about hemophilia. Yeah. All right. We shall move on to talk about the cellular system, whereby we shall talk about carcinogenesis, leukemia, lymphomas, Hodgkin's and non-Hodgkin's lymphoma, and then Wilms tumor. Yeah, all those we shall talk about. And then within the integumentary system, we shall talk about things like scabies, boils, and abscesses. We shall talk about things like lice, ringworms, among other things. Yeah. In the common tropical diseases or conditions, we shall talk about malaria, typhoid fever, chickenpox, otitis media, worm infestation, sites, among others. And then we shall also talk about nutrition. Here, we shall basically mainly dwell on malnutrition and how it is actually managed. So here we shall look at the the integrated management of acute malnutrition, whereby we shall classify malnutrition and we shall see how it is basically managed. Yeah. We shall move on to look at immunizable diseases, tetanus, tetanus, measles, whooping cough, among other conditions. Yeah. Now, you realize, if you have noted, most of these conditions we have actually covered. We have just finished with due control communicable and non-communicable diseases, and these things are not new. So, what does that entail you to do? While the lecturer will present some of these things, like for example, I will go ahead and present the cellular system and immune and cellular system, as well as carcinogenesis, where we shall talk about leukemia, Burkitt's lymphoma, Hodgkin's, non-Hodgkin's lymphoma, and Wilms tumor. You will be required, ladies and gentlemen, to present some of these things. Like, for example, scabies we did, boils we did, eczema, lice, the ringworms, these we did in control of communicable and non-communicable diseases. So you will be required to make presentations. John, please take notes. John, take notes. You are going to get the course outline, and then you will be able to subdivide these presentations. People are going to make these presentations right from anemia, sickle cell disease. The lecturer will talk about DIC, hemophilia, and then I'll also talk about the cellular system, carcinogenesis. Yeah. But the rest of the presentations, please, John, I'll also talk about malnutrition, by the way. I'll also talk about malnutrition. But the rest of the presentations, John, please do the needful. I repeat, John, you will be required to do the needful. Yeah. So I'm going to give you this course outline, and then you will subdivide these as required. Yeah. So without wasting any more time, we want to cover something today. Yeah. And in today's topic, we are going to talk about the proliferative disorders of the red blood cells, yeah? Proliferative disorders of red blood cells, yes? So just to adjust it a little bit. So we shall be talking about the proliferative disorders of red blood cells. And in here, ladies and gentlemen, if you're inquisitive, we shall cover things like leukemia, we shall cover the lymphomas, yeah? So in other words, we are going to cover, or we are going to tackle the cellular, the cellular system and carcinogenesis, yeah? So that's what we are going to tackle for today's lecture, and we shall see when to finish it, or when to do away with it. But for today, this is what we are going to talk about: proliferative disorders of the of the white blood cells, the WBCs, right? Okay, so I'm going to stop the slide share. I'm going to stop the slide share, and then I'm going to basically I'm going to first tell you a few things before I again resume the slide share. And so you must understand some of these principles before you understand what leukemias are and what lymphomas are. These are things that are usually confusing, especially to the nurses. These things usually confuse us, but I pray that today you learn something out of them, because we are going to learn some of these things right from first principles, yeah? Right. So when we talk about proliferative disorders of white blood cells, yeah, it is important to note that they are of two types. They are of two types, yeah? So we have what we call the reactive proliferation. We have what we call the reactive proliferation. And then we have what we call the neoplastic proliferation. So when we talk about proliferation, ladies and gentlemen, I hope you know that proliferation is basically dividing and accumulation in number of these white blood cells. So when we talk about proliferation, we are talking about dividing, and then these cells divide and they end up accumulating in numbers, in big numbers, right? Okay. So to talk about reactive proliferation, let's first talk about reactive proliferation. Yeah, we are going to talk about this when this basically here. We shall, under this one we have things like, we have leukemias and lymphomas under here. Yeah, under here we have leukemias and lymphomas. So let's first talk about reactive proliferation. Now, what is reactive proliferation? Yeah, the word reactive, just like the word reactive is, we see accumulation or an increase in the number of red blood cells as a result of infection. Yeah, so we see an increase in the number of white blood cells as a result of infection, nothing else but infection. Yes? Now, so you know very well that when we do a CBC, yeah, we usually look at the white blood cell counts, yeah, and when there is an infection, then usually an infection is indicative of the numbers, or the increased numbers of white blood cells, yeah? Now, with reactive proliferation, basically, there is some kind of infection, as I said, or there is some kind of inflammation, yeah, in the body, yeah? or there is some kind of, response, stress, yeah, that the body has to respond to, yeah. And in that case, we get what we call reactive proliferation. So we basically have to, we usually have an increase in the number of white blood cells, yeah. So in reactive proliferation, just any proliferation, you have an increase in the number of white blood cells. Now, you need to know the actual number of white blood cells when you do a CBC. What is the normal? What is the normal number of white blood cells? So the normal number of white blood cells is about 5 to 10,000. Yeah. So 5,000, not just 5, but 5,000 to 10,000, 5,000 to 10,000 per microliter. So that's usually the normal. Of course, it can be maybe 4,500, to 11,000. So, but usually the range is that. So, for you to understand reactive proliferation, you need to know the normal number of white blood cells in the body. Yeah, the normal number of white blood cells in the body. It's usually about 5,000 to 10,000 per microliter. Now, reactive proliferation is divided into two. Yeah, is also divided into two. One is we have what we call a simple leukocytosis. Yeah, simple leukocytosis. And of course, leukocytes are white blood cells. So when we talk about a simple leukocytosis, leukocytosis basically means an increase in the white blood cells. So we have a simple leukocytosis. So here, in a simple leukocytosis, yeah, the white blood cells do not, they do not so much increase in number. Yeah, so they are within, they basically increase slightly from the normal range. Yeah, they increase slightly from the normal range. Yeah, so those white blood cells increase slightly from the normal range. Increase slightly. So you can find maybe about. Remember, we said the normal is about 5,000 to 10,000 per microliter. Yeah. So that basically means if in a simple leukocytosis, you can have maybe an increment of up to maybe 12,000. Yeah. Maybe 12,000, or maybe an increase of about maybe 15,000. Yeah. So that is what we refer to as a simple leukocytosis. Yeah. Now, of course, when we talk about what might cause a simple leukocytosis, we are going to let's talk about this. Maybe the other thing that we should talk about is that when you're looking at a CBC, if you have looked at a CBC, you realize that they give you the differential cells of the white blood cells, but they also give you the total, the total number of white blood cells. And then they also give you the differentials. Yeah, they also give you the differentials. Yeah. So in a simple leukocytosis, you can have like for example, the neutrophils, yeah, increasing in number because of if there is a serious pyogenic bacterial infection, yeah, you can have the neutrophils increasing in number, yeah. You can have the neutrophils increasing in number, and of course this is referred to as neutrophilic leukocytosis, or the same or similarly known as neutrophilia, yeah. So if you have the neutrophils increase in number, if you have the neutrophils increase in number, if you have them increase in number, we refer to that as neutrophilic leukocytosis or neutrophilia. And this is usually as a result of, a pyogenic or a bacterial infection. Yeah. Now, you can also have an increase in number of eosinophils. Eosinophils, like for example in parasitic infections. Yeah. Like for example in parasitic infections, you can have an increase in number of eosinophils. You can have an increase in number of eosinophils, and this is what we call eosinophilic leukocytosis or eosinophilia. I repeat, you can also have, in case of maybe parasitic infections, you can have an increase in number of eosinophils, yeah, and this is referred to as eosinophilic leukocytosis or eosinophilia. Yes. Now you can also have an increase in number of basophils, yeah, like for example in case of allergic reactions, drug reactions, or some kind of neoplasia, yeah. In case of allergic reactions, a drug reaction, or some kind of neoplasia, you can also have an increase in the basophils, yeah, basophils. And of course, this is referred to as basophilia or basophilic leukocytosis, yeah. And then you can also have an increase in number of monocytes, yeah. In case of a chronic infection, yeah, in case of chronic infection or chronic inflammation, you can have an increase in number of monocytes, and of course that would be referred to as monocytic leukocytosis or monocytosis, yeah. Or you can even have an increased number of lymphocytes, yeah, like for example in case of a viral infection or under TB, in case of a TB infection, yeah. So you can also have an increase in number of lymphocytes, which we call lymphocytic leukocytosis or lymphocytosis, yeah. So what are we saying? We are saying that in a simple leukocytosis, you basically you have an increase in number of white blood cells, yeah. But remember, the white blood cells, you can have proportionate adjustments in the different cells that make the white blood cells, yeah. So you can have a neutrophilia, you can have an eosinophilia, you can have a basophilia, you can have a lymphocytosis, you can have a monocytosis, yeah. So, but all that, as long as the number of white blood cells has not so much increased, yeah, to maybe the increment is about maybe 15,000 or maybe 16,000. We refer to that as a simple leukocytosis. Now, the other subtype of reactive proliferation is what we refer to as a leukemoid reaction. The other type of reactive proliferation is what we refer to as a leukemoid reaction. Maybe the other thing, ladies and gentlemen, that you should know, you should also know the normal numbers, the normal percentages of this, yeah, of these. The normal percentages of these, yeah. neutrophils, eosinophils, basophils, leukocytes, rather lymphocytes among others. And neutrophils usually are of greatest percentage. Usually their percentage is between 60 to 70%. Yeah, and then followed by lymphocytes, followed by monocytes, followed by eosinophils, and then lastly basophils. So your assignment is to find the normal numbers of these. Yeah, please find out the normal percentages of these cells that make up the white blood cells. Yeah, that is your assignment that I've given you, right? Okay, good. Now, the other subsection or the other subtype of reactive proliferation is what we call a leukemoid reaction. Is what we call a leukemoid reaction. Now, in a leukemoid reaction, is what we call a leukemoid. B is what we call a leukemoid reaction. Yeah. So in a leukemoid reaction, yeah, basically, this can either be a C or it can be a K, depending on how you write it. Yeah. So in a leukemoid reaction, basically what happens is that we have, excessively increased numbers of white blood cells. Yeah. So they usually go, they can go up to. They can go up to 30,000 to 50. So in a leukemoid reaction, you have excessive increase in white blood cells. Yeah, you have excessive increase in white blood cells, and usually they can go even up to these ranges, 30,000 to 50,000. Now, what are some of these? Basically, in a leukemoid reaction, what are some of the things that cause an increase in this number of white blood cells? You have things like severe and sustained stress and trauma. Yeah, and so severe and sustained stress and trauma can basically bring about a leukemoid reaction, whereby you have increased numbers of white blood cells. Yeah, you have a very, very increased number of white blood cells as a result of sustained stress, surgery, or even trauma. Yeah. So now this is basically another subtype under reactive proliferation. Now, I hope this is clear. Yeah, I want to repeat a little bit before I go to neoplastic proliferation. When we talk about proliferative disorders of white blood cells, yeah, we basically mean the white blood cells increasing in number. Yeah, and when they increase in number, there can be two things or two causes. Let me say there can be two causes. It can be as a result of them reacting to something, yeah, what we call reactive proliferation, or it can be neoplastic, yeah. And in neoplastic, we are going to talk about things like leukemia and lymphomas, yeah, neoplastic proliferation, yes. Now, when we talk about reactive proliferation, it is also divided into two. There's what we call a simple leukocytosis, whereby you have an increase in the number of white blood cells, but this increase in number of white blood cells does not exceed 20,000, it doesn't usually exceed 20,000 per microliter, yeah? And of course, we are saying that for you to be able to tell the kind of proliferation, then you need to know the normal numbers of white blood cells. And these white blood cells, we say the normal range usually is between 5,000 to 10,000 per microliter. Yeah. Of course, some books say 4,500 to 11,000 per microliter, but again, it's not a very big discrepancy. Now, when you have an increment, yeah, which does not go beyond 20,000 cells per microliter, then that is referred to as a simple leukocytosis. Yeah, and of course, you should know that white blood cells have, you know, white blood cells have what should I say, types of white blood cells, whereby you have the granulocytes and you know, and the agranulocytes. So there is also, when you have a simple leukocytosis, you should also expect to have proportionate changes in these different types of cells. You can either have a neutrophilia. So depending on the condition, if there is a bacterial infection, then you'll be expected to have a neutrophilia. If there is a parasitic infection, then you'll be expected to have an eosinophilia. If you have, you know, a chronic infection, yeah, or if you have and if you have a chronic infection, then you'll be expected to have, you know, a kind of change in a particular category of you know, of white blood cells. If you have allergy, or if you have among other things that we have talked about, yeah, if you have a viral infection, yeah, so you will have a change in maybe the lymphocytes and all those things. So it is very important for you to know the underlying cause or the underlying problem, yeah, for you to know. And if you realize an increase in one of those, then you should also have a clue about the underlying problem of this patient. Now, the other one we said is leukomoid reaction, whereby there is excessive increase in the number of white blood cells. Usually the range is that. And what usually causes this is sustained stress and trauma, yeah? Sustained stress and trauma on, you know, on the body, yeah? On the body. And basically you have a leukomoid kind of reaction, yeah? Now, that is it about reactive proliferation, yeah? Now, we want to talk about neoplastic, yeah? Neoplastic proliferation. Neoplastic proliferation. And under neoplastic proliferation, we shall talk about things like leukemia and lymphomas, yeah? We shall talk about leukemia and lymphomas. So under neoplastic proliferation, we are going to talk about leukemias and lymphomas. We shall talk about leukemias and now, it is very important for you to differentiate these two, yeah? It is very important for you to differentiate these two, yeah? And so before I go any further, I need to show you, you know, the cellular origin of white blood cells, or even other, you know, of other cells. Yeah. So you need to know. I'm going to project this so that you see the cellular origin of these cells. Yeah. So when we talk about the cellular origin of these cells, we basically mean something like this. So when we talk about the cellular origin, of these cells, I hope you're seeing that. Yeah, I hope you're seeing what is on the screen there. Yeah. Now it is very important for you to understand that. It is very important for you to understand that diagram, ladies and gentlemen. Now, just to explain it a little bit, ladies and gentlemen, all cells start from what we call the blood stem cell, as you can see there. Yeah. Then it divides into what we call the myeloid stem cell, and it also divides into what we call the lymphoid stem cell. Yeah. If it confuses you, just say LM. Yeah. LM. If it confuses you, just say LM, the lymphoid and the myeloid. Is that okay? The lymphoid and the myeloid. So the blood stem cell basically divides into those two, yeah? Into the lymphoid and the myeloid stem cells. Now, the lymphoid stem cell basically divides into, or it gives rise to the lymphocytes. Yeah, it gives rise to the lymphocytes, and as you can see, it basically divides into what we call a lymphoblast, and then that lymphoblast subdivides into the B cell lymphocytes, the C cell lymphocytes, and the natural killer T cells, the natural killer cells rather. Yeah. On the other hand, you have the myeloid stem cell. Yeah. It basically gives rise to three things. Yeah. It gives rise to the red blood cells. It gives rise to the platelets, and then it also gives rise to the rest of the white blood cells. Yeah. What we refer to as the granulocytes. Yeah. It gives rise to the rest of the white blood cells, which we refer to as the granulocytes, which we have the eosinophils, the neutrophils, the basophils. Yeah, so those are referred to as granulocytes. Now, it is very important for you to understand that. It is very important for you to understand that before we continue or before we proceed to go any further. Now, my assumption is that you have understood that, so we can basically proceed. All right. So, when we talk about leukemia, a leukemia is basically a neoplastic proliferation. Yeah, neoplastic, neo. In other words, it's abnormal, malignant. Yeah, neoplastic proliferation of hemopoietic precursor cells. Yeah, hemopoietic precursor cells. Now, it does not matter. Please note this. It does not matter whether it is lymphoid or myeloid. No, it does not matter. A leukemia is basically, neoplastic proliferation of hemopoietic precursor cells. Yeah, it is neoplastic proliferation of hemopoietic. So this may be lymphoid or myeloid. This may be lymphoid or myeloid in nature. It doesn't really matter. It doesn't matter which whatever. They can be either lymphoid or myeloid. Now, the special feature with leukemias, yeah. If I can demonstrate something, if I can demonstrate something here, the special feature with leukemias, if this is the bone marrow house, where blood is coming from, and so the special feature with leukemia is that you have, what you do is you have a stem cell, which basically divides, or which produces, you know, the lymphoid and all the myeloid. Yeah. So you have excessive division. Yeah. You have excessive division of these. It is too excessive that it basically it infiltrates the whole, you know, the whole bone marrow, and it even goes into the blood circulation. Yeah. It goes into the blood circulation, and you know, and other lymphoid and the liver and other lymphoid structures. Yeah, the thymus and the spleen. Yeah, so it diffuses, it basically infiltrates the whole bone marrow, and even spills into blood. Yeah, it even spills into blood, and you know, and other structures. Yeah. So with leukemia is that you have excessive proliferation. Yeah, you have excessive proliferation of these you know, hemopoietic stem cells, and so leading it basically spreads like milk. Yeah, it's like it infiltrates the whole bone marrow, and even, you know, and even goes into the blood circulation. Yeah, so you have a lot of you know, immature, you know, immature cells of the hemopoietic stem, you know, the hemopoietic precursor cells. Yeah, so it spills into circulation. Yeah, and so that is basically what leukemias are. Yeah, so you have excessive formation or excessive division of these precursor cells. Yeah, which, you know, which infiltrates or diffusely proliferate in the bone marrow, and eventually infiltrate, you know, the blood and other structures. Yeah. Now, that is the special feature with leukemias. That is the special feature with leukemias. Now, on the other hand, lymphomas, you know the difference between butter and milk? The difference between butter and milk is, you know, the fluidity. Yeah, the fluidity. So it's like these leukemias are like your, with the leukemias, it's like you're pouring milk. Yeah, it's like you're pouring milk. It is too much, and then it eventually it goes, even it spills into the blood, you know, into the blood circulation. However, with lymphomas, still it is basically the same thing. Yeah, it is basically the same thing. But what actually happens is that as these cells undergo neoplastic proliferation, yeah, as these cells undergo you know, neoplastic proliferation, they do not spill. Yeah, they do not spill. Instead, they form discrete masses. Yeah, they form discrete masses within the bone marrow, within the lymph nodes, you know, and basically they are discrete masses like butter. Yeah, like butter. In other words, they form masses. Yeah, they form masses. While lymphomas, they basically diffuse throughout, you know, throughout the body and the blood circulation. Yeah, so that is the main difference between lymphomas and leukemias. Yeah, the main difference, that's the main difference between lymphomas and leukemias. Again, I want to repeat is that as in lymphomas, as these precursor cells, as these neoplastic, you know, cells, you know, proliferate. Yeah, they tend to form discrete masses. They tend to hold on to each other, forming masses. Yeah, they tend to hold on to each other. Again, I'll use this very diagram. Yeah, they tend to hold on to each other, and then they form masses. Yeah, so you can find a mass within the bone marrow. Yeah, you can find a mass within the bone marrow, and that those also that go and spill into blood, they end up forming masses in the lymph nodes. You know, they end up forming masses in the lymph nodes, maybe in the GI, among others. lymphomas basically form masses, while a leukemia basically for them they are diffused throughout, throughout the body. Yeah. So the main difference between lymphomas and leukemias is basically the way they spread and behave in the body. Yeah. Now, I want you to also understand that sometimes a patient might come to the physician, yeah, and maybe they have a primary diagnosis of leukemia, yeah, they have a primary diagnosis of leukemia, but after some time, you know, a lymphoma forms, yeah, like for example, a swelling forms, yeah, so that basically means that the leukemia has turned into a lymphoma. In other words, the milk has turned into the butter, yeah. On the other hand, also sometimes a patient can come with a mass, with just a mass, yeah, with just a mass, yeah, or a lymphoma. But after some time, yeah, when investigations are done, then they realize that this patient has a, a leukemia, yeah, a leukemia. So that basically means that this leukemia has basically, rather this lymphoma has also basically maybe turned into a leukemia for that matter. Yeah. So I felt you needed to understand this before we go into the presentations for leukemia and lymphomas. Yeah. Maybe the other thing I should explain before we go into the detail, before we go into the presentation of leukemia and lymphomas, is the fact that depending on where the arrest of differentiation has been, yeah, then you tend to have either acute or chronic, yeah. Then you tend to have either acute or chronic. All right. So let me just demonstrate that here. If this is our blood cell, yeah, this is our blood cell, and this blood cell basically undergoes it undergoes a few whatevers. It undergoes a few stages before it eventually turns into a blast, yeah. Before it turns into a blast, yeah. Before it turns into a blast. So this is the stem cell, yeah. Before it eventually turns into a blast. Now, if we are to compare, if we are talking about the maybe that the lymphoid, the lymphoid stem cells. This is our lymphoid stem cell. Then it will give rise to, what will it give rise to? All right. So it gives rise to the B cell, the T cell, and so it gives rise to the B, the T, and the natural killer T cell, rather the natural killer cells, right? Okay, now, if the arrests, maybe I should also mention that as you move towards this direction, as you move towards that direction, what actually happens is that the cells become more differentiated. The cells, as you move towards this direction, yeah, the cells become more differentiated. They become more differentiated. They become smaller. In other words, the blast is bigger. A blast, this one is bigger than, So as you move towards that side, the cells become more differentiated. More differentiated basically means they are able to perform their function. Yeah, they are able to perform their function. So as you move towards that, the cells become more differentiated. They become smaller and even less dividing. Less dividing. You have less division or less division or proliferation. You have less division or proliferation as you move towards that direction. Now, please pay attention here. Pay attention here. Now, when because we are going to, of course, we are going to see some the etiology or the risk factors to leukemias. Yeah. Now, when arrest, yeah, when the arrest of differentiation occurs at this point, yeah, when the arrest of differentiation probably occurs at that point, yeah, let's call this point A, yeah, and if the arrest of differentiation maybe occurs at this point B, yeah, if the arrest of differentiation occurs at this point, yeah, and also if the arrest of differentiation does not occur here, but it basically occurs at this point, what happens? What happens is that at this point here, at this point, cells are rapidly dividing. At this point, cells are rapidly, remember we said as we move this side, we have less dividing. So in these earlier points, the cells are rapidly dividing. Please note that. While at this point, cells are not as they are not as rapidly dividing. Yeah, they are not as rapidly dividing. Please note that. Now, because of that, yeah, because cells here are rapidly dividing, yeah, in this region, because cells are rapidly dividing, if a patient has an arrest of differentiation at this point, what do you think would the problem be acute or the problem will be chronic? Or let me say, do you think the problem would be severe or more aggressive, or it would be less aggressive? All right. So I think you have said that the problem would actually, it would be more aggressive here. Yeah. Remember here the cells are rapidly dividing. The cells are rapidly dividing. Yeah. So they're increasing in number. Yeah. But at this point, the cells are not as rapidly dividing. Yes, they are dividing, but not as rapidly dividing. Yeah. And so, a condition here would be more aggressive. If a patient comes when differentiation was arrested at this point, then it would be more aggressive compared to here. And so, here, we usually refer to it as acute. I repeat, at this point, the cells will be more rapidly dividing, and so the condition will be more aggressive, and therefore we refer to this as acute. On this point, the cells are not as rapidly dividing as these ones, yeah? And also, the cells are a little bit differentiated, more differentiated than these ones. And also, they are even smaller than these ones. And so at this point, the cells are, we refer to this, this point would be more of a chronic, yeah? In other words, if a patient comes at this stage, if a patient is at this stage, then the condition is chronic. Chronic, in other words, they would really, if it is in terms of survival, this patient would have many more years of survival compared to this one. Now, the other thing that I wanted to say is that as you move towards this side, they become lymphocytic sites, lymphocytic. As you move towards this side, they become cytic. Cytic, lymphocytic. Yeah, because these are lymphocytes, right? So they become lymphocytic. Lymphocytic. But when you're towards this side, it is blastic. Blastic. Because it is still blast. So it becomes blastic. Yeah. So as you move, this side, it is blastic. Now, please pay attention, because this is very critical when you are classifying. We are going to classify the leukemias. We are going to classify the leukemia. So this is very, very important. Yeah. So as you move towards that side, the cells become smaller. They become they are more differentiated, and they are less dividing. On this side, ladies and gentlemen, the cells are blastic. In other words, they are bigger, they are more dividing, and they are less differentiated. In other words, they do not perform, they cannot perform the functions they are supposed to, because they are less differentiated. I hope that is clear. I hope that is clear. Ivan, I hope that is clear to you. John, I hope that is clear. Yes, Doloka, I hope that is clear. So basically, blastic, cystic, yeah? So I felt you should understand that, yeah? Before we go into the details of leukemias, yeah? Because you're going to realize that there are some types, and you know, they really tend to confuse, yeah? They really tend to confuse. So you should be able to understand that. Now, the point to take home here is that you need to understand this. You need to understand the development of these cells, and you also need to understand the fact that as you move this side, the cells become smaller, and as you move this side, when you're this side, the cells are bigger. Rehma, the cells become bigger. All right, now, basically, this is going to form the basis of our classification of leukemias, right? This is going to form the basis of our classification of leukemias. Now, according to the WHO classification of leukemias, yeah, we shall note that according to the WHO classification of leukemias, we are going to note that they are basically divided into we have what we call the lymphoid. We have what we call the myeloid. And what we shall not handle is the histiocytic. So we are not mainly going to look at these two, but of course they are going to come up as I make the presentation to you. But just for purposes of clarification, yeah. For the lymphoid, I hope you still remember the lymphoid, the lymphoid section or the lymphoid stem cell, whereby we have the B cells, we have the T cells, and we also have the natural killer, yeah, the natural killer cells, yeah. So whenever, according to the WHO classification of these leukemias, or even maybe lymphomas, yeah, basically you have what we call the precursor B cell. Precursor B cell leukemia. Yeah, precursor B cell leukemia. Now, when we talk about precursor B cell, remember this is a stem cell. This is a blast, and then it basically forms 3. Yeah. So when we talk about, of course, here it goes on differentiating. So when we talk about precursor B cell, it basically means that that cell basically arrested in the precursor stages, but when it is investigated or when it is looked at critically, it has properties of a B cell. Yeah, that is basically what it means as precursor B cell. Yeah, it basically the differentiation arrested at this point, usually at that point. Yeah, but when that cell is looked at critically by those specialists, yeah, then it has properties of a B cell. Yeah, so that is what we refer to as precursor B cell. Now I want to ask, is this precursor B cell leukemia acute or chronic? From what we were talking about, is it acute or chronic? Yes, it would be acute. Yeah, so it would basically be acute because it basically arrested at this point. So so that is where you have what we call acute lymphoblastic leukemias. Yeah, that's why you have acute lymphoblastic leukemia. So you're going to find this in the classification of leukemias. In the presentation that I'm going to make, you're going to find it quite often. So please do not say, now where does this one come from? No, it is precursor B cell at this point, and for that matter, it is acute. Yeah, and it is lymphoblastic. This L stands for lymphoblastic, not lymphocytic, but lymphoblastic, because it got arrested before this point. It did not get arrested after this point. If it was this point, then it would be lymphocytic. But if it is at this point, then it is lymphoblastic. Is that clear? All right. And then you can also have what we call the peripheral B cell. Peripheral B cell, yeah? Peripheral B cell leukemia, yeah? So with peripheral, we basically mean it's towards this point, yeah? It's towards, because peripheral basically means at this point, these things are even going into blood, yeah? So peripheral B cell is basically, arrest is around there, yeah? It's around that point, yeah? And so, would this be acute or chronic? Yes, it would be chronic, yeah? So it would be chronic. So this is where you find things like chronic lymphoblastic, chronic lymphoblastic leukemia, yeah? So basically, and the list goes on for T cells and natural killer cells. So something like that, yeah? The list goes on for T cells and natural killer cells. Now, I felt you needed to understand this. Yeah, I felt you needed to understand this before we go into, the presentation. Yeah. Now, the other thing that I want to also tell you briefly before we go into its presentation are the lymphomas. Yeah. Remember, we talked about them briefly. Yeah. We talked about them briefly, and we said it's like butter. It's like butter. They end up forming, masses. The cells clamp each other, and they end up forming masses. Yeah. So lymphomas are basically cohesive tumors, cohesive tumors of the immune system. Yeah, and they are divided into two. Yeah, they are divided into two. There's what we call Hodgkin's lymphoma, Hodgkin's Hodgkin's lymphoma and non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma. Now, these two are basically lymphomas, yeah? These two are basically lymphomas, but they can be differentiated, yeah? They can be differentiated. Maybe the very first differentiation that you should not forget, the very first difference that you should not forget, and of course this is done histopathologically, is the presence of what we call the Reed-Sternberg cells, yeah? The Reed-Sternberg cells. Reed-Sternberg cells, yeah, in Hodgkin's lymphoma. What are these cells? These are basically cells that it's basically a big cell that has two nuclei and the central, the central port. So they are like the owls. Have you seen a bird which looks like this? An owl, yeah. So they look like an owl, yeah. So an owl, yeah. So that is these are what we call the Reed-Sternberg cells. They are classical for Hodgkin's lymphoma. They are classical for Hodgkin's lymphoma, and they are not present in non-Hodgkin's lymphoma. But the other difference between Hodgkin's and non-Hodgkin's is that Hodgkin's basically originate from nodal tissue and usually are accessible. So you basically, they originate from nodal tissue, yeah? So you can see maybe a swelling in the node here, these nodes here, or you can see a swelling, in the nodes here. So they basically originate from nodal tissue. And here they usually originate from internal structures, yeah? And extranodal tissues. Like for example, in the GI, where places that are not easily accessible, yeah? But of course, that is not all these originate from places that are not easily accessible, but most of them originate from there. Now, these ones basically spread in a predictable manner. Yeah, if it started here, yeah, you would expect it to come down like this, to come here, come here, come here, like that. Yeah, the Hodgkins. Yeah, but the non-Hodgkins are basically unpredictable. If it started somewhere, you cannot tell where next it will go. Yeah, so the Hodgkin's lymphomas are basically predictable. Yeah, and they are also good at when treatment is given, yeah, chemotherapy is given, they are good at responding to chemotherapy compared to non-Hodgkin's lymphomas. Yeah. Now, I hope you have understood, or I hope you have a clue, because now we are going to make a presentation. Yeah, I'm going to display a presentation on leukemias and lymphomas. Yeah, but my assumption is that as I present these things, you reflect on what I talked about. Yeah, so that you can easily know what you can easily understand. Is that okay? All right. So let's start with the leukemias. Yeah. Let us start with leukemias, and then we shall proceed with the lymphomas. Yeah. So let us start with leukemias. Let's start with leukemia. So I'm going to display this presentation that is basically on leukemia. Yeah. Right. So this presentation on leukemia. So this presentation on leukemia. All right. So I think we can move on from there. Yeah. So we are saying what are leukemias? Basically, the word leukemia comes from two words. It's a Greek word that comes from leukos and ima. Yeah, and ima. And of course, leukos means white, and then ima means blood. So white blood cells. Yeah, white blood cells. And the cells basically are committed to produce specific types of cells. We have seen this. We have seen this already. Yeah, that stem cells. Yeah, we have seen that stem cells produce specific types of blood cells. Yeah, and so the stem cells can be it always starts from the blood stem cell, which gives rise to myeloid and then the lymphoid. Yeah. So the lymphoid stem cell produces the B lymphocytes and the T lymphocytes and the natural killer cells. Don't forget that. And then the myeloid stem cell basically gives rise to three types. It gives rise to the red blood cells, it gives rise to the platelets, and then it gives rise to the rest of the red blood of the white blood cells, as you can see there. Yeah, as you can see there. Now, what is the function of the bone marrow? We are not going to go into the details of that, but you know, in the bone marrow, this is where blood cells are formed. Yeah, this is where blood forms are formed. And then we have two types of bone marrow, where we have the red and the yellow bone marrow. Yeah. The red marrow is found in the flat bones, and so the flat bones are bones like you know, the sternum, you know, the skull. All those are flat bones. Even the ribs, the hips, all those are flat bones. Yeah, and also it is also found in the ends of the long bones. Yeah, so the white cells. These are basically the white, of course. The white blood cells, the platelets, and the red blood cells are basically produced in the, you know, in this red marrow. Yeah, as we have mentioned. Yeah, and then the yellow marrow is also found inside the, you know, the middle section of the long bones. Yeah. Now, what are the functions? Of course, you know the functions of these. Yeah. Now, we mentioned, or we said that leukemias is basically a neoplastic proliferation of, you know, of the hematopoietic precursor cells. Yeah. So here they have defined it as a group of malignant disorders affecting the blood and blood-forming tissue of the bone marrow. So leukemias basically they can form, or they can start within the bone marrow, and then they spill into the blood, or they can start, by the way, into the, you know, they can start from the lymphatic system. Yeah, or the lymphoid tissue. Yeah, so that is very important to know. Now, what basically causes this? What causes? Now, we do not know. We do not know. Actually, when we say etiology, it's not the right thing. Yeah, what we should talk about, or what we should mention. What we should mention are what we call the risk factors. Yeah, what we should mention are the risk factors. Yeah, so things like predisposing factors, things like environmental influences, exposure to chemicals, things like cytotoxic substances, radioactive exposure. All these expose you to getting leukemia. Yeah, and then congenital abnormalities, presence of primary immunodeficiency, like even in HIV, HIV patients can end up with leukemias or even lymphomas. Yeah. So immunosuppression essentially can also predispose you to getting lymphomas. This diagram we have already seen, and so what actually happens is that the lack of control, because of the other factors we've talked about, the blood cells, the blood cells, they lose their ability to control themselves, or so the normal bone marrow is basically because of lack of control, lack of control of cell division, the bone marrow is basically replaced by immature and undifferentiated leukocytes, or what we refer to as the blasts. So these then circulate in the blood and infiltrate the blood, and it also infiltrates the blood-forming organs like the liver. So that is what we are talking about. So in leukemia, what actually happens is that there is too much. The cells lose control and they start proliferating too much. And then they even spill into the blood and also go into other blood forming or tissues, and even other cells throughout the body. Now, what are the different types of leukemia? What are the different types of leukemia? Now, it may be acute or chronic. Remember what we said. It may be acute or chronic, depending on the place, or let me say the site of loss of differentiation. Remember we said that if differentiation is lost in the early stages, then that is acute. If differentiation is lost in the late stages, then that is chronic. So it may be acute or chronic. Acute leukemia get worse very fast and may make the patient feel sick right away. Because of the too much cell division. So they get they become acute and very aggressive. So basically, so while in chronic leukemias, the patient gets worse slowly, and the symptoms may be there for years. Is that clear? Javier, is that clear? All right. So it is also very important for you to know lymphocytic and myelocytic. Remember, we said the lymphoid and the myeloid. So they can also be subdivided into myelocytic or lymphocytic. I don't want you to be confused about that. Now, if the cancerous change occurs in the type of bone marrow cells that produce the red cells, then other types of white blood cells and platelets, the disease is then referred to as myelogenous leukemia. So that is why we said it does not matter. It does not matter which cell line. Basically, leukemia can occur in whichever cell line. They can occur in whichever cell line. Okay, now what is the incidence? In adults, basically chronic lymphocytic leukemia and acute myelogenous leukemia are basically most common. They are most common. They are the most common leukemias. While in children, acute lymphoblastic. I hope you note that acute is followed by lymphoblastic. Why? Because the differentiation was arrested during these blastic stages, at the blastic stages. That's why it's called acute lymphoblastic, acute lymphoblastic leukemia. So this one is prevalent in children, and also acute myelogenous, leukemia, and other myeloid leukemias, such as chronic myelogenous leukemia and then juvenile myelomonocytic leukemia. Yeah, so these are also prevalent in children. Yeah, all right. Now, what are other related problems? What does leukemia cause? Yeah, having too many cells would actually not be a problem, but what actually happens is that these cells multiply too much that they even suppress even the normal cells. Yeah, these cells, I repeat, these cells multiply or they proliferate too much that they end up even suppressing the normal cells. So what problems come up? So bone marrow failure, yeah, bone marrow failure, because these abnormal cells overcrowd, yeah, they overcrowd the bone marrow, yeah, they overcrowd the bone marrow, and also they start competing with the normal cells, but also they even start eating up, they eat up all the nutrients, yeah, they eat up all the nutrients, yeah. So that is the problem. That is one of the problems. So bone marrow failure as a result of overcrowding by abnormal cells, inadequate production of normal bone marrow elements, and then anemia, thrombocytopenia, and a decrease in the number, or rather a decrease in the function of white blood cells. So why do we have anemia? Because even the production of red blood cells will be affected. Why do we have thrombocytopenia? Is because even the production of platelets will also be affected. Why do we have a decrease in the function of the red blood or the white blood cells? Is because the large numbers of the cells that are within the bone marrow are undifferentiated and therefore are unable to perform their function. Yeah. So then the little normal white blood cells, their function is basically decreased. I hope you understand that. All right. What are the related problems caused by leukemia? Cells infiltrate patients' organs, and they can also end up having splenomegaly, hepatomegaly, lymphadenopathy, bone pain, meningeal irritation, and even oral lesions. Yeah. Now, let's look at the classification of leukemia. We have I already had had a glimpse on this. Yeah. So one is acute. That word is not lymphatic. Instead, that word is, what is that word? That word is acute lymphoblastic leukemia. Yeah, it's not lymphatic. It's not lymphatic. It is acute lymphoblastic leukemia. So this usually occurs in childhood, before 4 years of age, and basically the peak incidence is between 2 to 9 years. Yeah, the pathophysiology is basically it arising from a single lymphoid stem cell with impaired maculation and accumulation of these cells into the bone marrow, as what we have talked about earlier. Yeah. So basically, what are the signs and symptoms? Things like anemia, bleeding, yeah, because the platelets have been compromised, also lymphadenopathy and infection. Yeah. So what are the clinical manifestations? You have things like fever, pallor, bleeding, anorexia, fatigue, weakness, and joint pains, and all those, yeah, and all those issues. Yeah. You have generalized lymphadenopathy, you have infection. Remember, you have frequent infections because even the normal white blood cells are not being produced. Yeah. So you have frequent infections, you have anemia, you have bleeding, you have weight loss, and then you have sore mouth and sore throats. Yeah. How is it diagnosed? Of course, they do CBC, whereby they see a low red blood count. They do HB, hematocrit, low platelet count. So in other words, the other cell lines are low. Yeah, the other cell lines are low. Now I want you to find out the normal numbers of red blood cells, the normal HB, the normal platelet count. Yeah, please find out that. Yeah. And also, you see that in blood we see immature lymphoblasts. Yeah, we see immature lymphoblasts in blood. Yeah, so treatment, basically they do chemotherapy, and of course this is under two phases. There is what we call induction, consolidation, and maintenance. We are going to look at these in detail. They also do prophylactic treatments for prophylactic treatment of within the central nervous system, because some of these cells can basically infiltrate into the central nervous system. Yeah. So also diet is very important. Yeah, as they do this. Yeah. All right, so avoid infection. They are what we call leukopenic precautions. Yeah, the leukopenic leukopenic precautions. So in leukopenic precautions, what happens is that these are basically precautions that are geared towards preventing infections. Things like hand washing, things like avoiding crowds, things like not eating. Yeah, not eating. Like for example, when you get a mango, when you're to eat a mango, don't eat it live as we do. Yeah, you have to peel to remove that outer surface. Yeah. So all those are referred to as leukopenic precautions. Do not take flowers. Yeah, if the patient is sick with leukemia, do not take flower. Do not take them flowers to smell. Those flowers. No, all that will be predisposing them to infection. Yeah, so you have to do what we call leukopenic precautions. Leukopenic precautions, right? Take measures to decrease nausea and also promote appetite, and also maintain oral hygiene, yeah, because of the mouth sores. Now, that is an example, or that is remember we said that when blood is investigated, or when blood is looked into, they see lymphoblasts, yeah, they see blasts, yeah. You see how big those cells are, yeah? Those are basically lymphoblasts. So that is why it is called acute lymphoblastic leukemia. They are lymphoblasts. They are still big. They are big, as you can see in that diagram. Now, the other type of leukemia is what we call acute myeloblastic leukemia or acute myelogenous leukemia. Yeah, this one usually occurs at any age, but most often, adolescent and after the age of 55. Yeah, it is basically characterized by development of immature myeloblasts. Yeah, that is why it is called acute myeloblastic, yeah, leukemia, and that is why it is acute, because it is still in the blastic. Yeah, it is still in the blastic. Yeah, so that is why it is referred to as acute. So acute myeloblastic leukemia, basically characterized by immature myeloblasts in the bone marrow, and it is similar to acute lymphoblastic leukemia plus what we call the stenotenderness. Yeah, the stenotenderness. So as far as the classical, rather the clinical manifestations are concerned, basically they are similar. And then in the diagnosis, you basically see what we have seen earlier in lymphoblastic, but also you see a high count of white blood cells with a lot of myeloblasts. Treatment, we usually do chemotherapy. We shall not go into the details of chemotherapy because I think you did anti-cancer drugs, but also to appreciate more how these things are managed, you need to work at maybe at the Uganda Heart Institute. Yeah, so they usually give anti-cancer drugs. Yeah, use of anti-cancer drugs, and also almost the same care as patients who have acute lymphoblastic leukemia. Yeah, and also you give you know, fluids are very important, and also instruct the patient about the medication effects and all those things. Yeah? So in acute myeloblastic leukemia, you can see that the cells are still big. Yeah, you see that the cells are still big. That is why it is called myeloblastic. Now, in chronic, that word chronic goes with the word lymphocytic because it is towards the other side, yeah, as we mentioned earlier, yeah. So the other one is chronic lymphocytic leukemia, yeah. So in chronic lymphocytic leukemia, you have the incidence basically increases with age, and it is rare under the age of 35. The pathophysiology is basically characterized by proliferation of small. You remember small, because as you move towards that side, the cells become smaller. Yeah. So proliferation of small abnormal mature. Yeah. So they are kind of like mature. That is why it is chronic. It is not acute. Yeah. It is less aggressive. Yeah. Because there is at least there is some more degree of differentiation. Yeah. The arrest or differentiation of you know, you basically occurred at you know, quite a late stage, at a late you know, stage. Yeah. So there is small abnormal mature B cell lymphocytes, often leading to decreased synthesis of you know, immunoglobulin. You know very well that B cells are the ones that you know, end up into you know, leading to formation of immunoglobulins, yeah, or what we refer to as the, you know, the antibodies, yeah, and then you have a decreased antibody response, yeah. So the number of mature lymphocytes in peripheral blood smear are greatly increased, yeah. So so you have the number of mature lymphocytes in peripheral blood smear and bone marrow are greatly increased because still that is not good, ladies and gentlemen, because of what we say. Yeah, though they are mature, but since it is a neoplasm, since it is a neoplasia, it is not a good thing. Yeah. So clinical manifestations, usually there are no symptoms since it is chronic. Yeah. However, there is fatigue, weakness, anorexia, splenomegaly, and you know, hepatomegaly. What are the signs? You have pleuritic vascular skin lesions. You have anemia, thrombocytopenia. You know, the white cell count is between. I think you can now see, yeah, the neoplastic. You know, the neoplastic proliferation. You see that those very increased numbers of white blood cells. So it is very, very high. Yeah. So basically that is it. And then increase in blood viscosity and clotting episode. Yeah. All right. So chronic lymphocytic leukemia, how is it managed? Basically, persons are treated only when symptoms, you know, only when they have symptoms. And chemotherapy is usually also given, and the client and family education is that described for acute you know, myeloblastic myeloblastic leukemia. So in other words, we are saying that the family and the client should be educated on the acute myeloblastic, because sometimes, much as it is chronic, you might have some episodes of the acute. Yeah. So basically, you need to educate and a patient on the same. Yeah. Exactly. So if you can see the chronic lymphocytic leukemia, the cells are smaller. Yeah, the cells are smaller as we mentioned. Yeah, the cells are smaller. All right, so there is also what we call a chronic myelogenous, or what we call, or you can also call it chronic um, myelocytic. You can call it a chronic myelocytic leukemia. Yeah. So this one is basically associated with there's what we call a Philadelphia chromosome. Now, when a patient has when a patient is being diagnosed, yeah, for this condition, and then they find a Philadelphia chromosome, then the patient is said to have, acute, rather chronic myelocytic leukemia. So this is basically a chromosome. There is an abnormality that basically occurs in the chromosome, yeah, and then so that it produces this Philadelphia chromosome. So this Philadelphia chromosome is not a normal chromosome, yeah. Instead, it is an should I say, a problem occurs in the original normal chromosome, yeah, whereby there is translocation of some genes, yeah, giving rise to an abnormal chromosome, which we refer to as the Philadelphia chromosome, yeah. So the chromosome abnormality that causes this kind of leukemia. It occurs between 26 and 60 years of 25 and 60 years of age, with a peak incidence of about 45 years. Yeah, and benzene exposure. Yeah, benzene exposure and high doses of radiation have been associated with this. Yeah, usually there are no signs and symptoms. However, the minor ones can be fatigue, weakness, among others. Yeah. And we can also have massive splenomegaly. We can have accelerated phase of the disease, yeah, what we call the blastic phase, yeah, the blastic phase. Yeah? Remember, we said, yes, it is chronic, but then you can have an accelerated phase of the disease, yeah, what we call the blastic phase, yeah. And so it is characterized by increasing number of granulocytes in the peripheral blood, yeah? And there is corresponding anemia and thrombocytopenia for the same reasons that we actually say. Now, how is it diagnosed? Basically, you will read through this, yeah? And it's usually not so much different from the others, yeah? So treatment, we usually give anti-cancer drugs. Yeah. The only potential curative therapy is basically bone marrow transplant. Yeah. So the other are not curative per se. So you need a bone marrow transplant. Now, what are the different nursing interventions? Prevention, just like the others that we looked at earlier. Prevention of infection, whereby you need to put on what we call neutropenic precautions. Promoting safety, providing oral hygiene, preventing fatigue, among others. Yeah. So that is a typical example of chronic myelocytic or myelogenous leukemia, as you can see. That's the cells are small. The cells are small. So how do we manage? There's what we call watchful waiting. There's what we call chemotherapy, targeted therapy, radiation therapy, and then stem cell transplant. Yeah. So what do we mean by? So the overall this management is basically overall management of all the leukemias. Yeah. So watchful waiting, chemotherapy, targeted therapy, radiation, and stem cell transplant. Yeah. Now the choice of treatment basically depends on one, the type of leukemia. Is it acute or chronic? Yeah. Remember, we said acute ones are more aggressive, yeah, than the chronic. Yeah. And then it also age, yeah, the age at which this condition is, and whether the leukemias were found in CSF, yeah, because it would be very aggressive if they are found in the CSF, because they would end up into the brain. Now, what does watchful waiting mean? Yeah. So remember, we said with the chronic leukemia, yeah, usually there are no signs, there are no specific signs and symptoms, yeah, or it's not very aggressive. So you might need to basically watch, watch closely, watch closely. If you need to watch closely, you need to watch closely with this patient, especially those who do not have, signs and symptoms. So you watch for health closely so that the treatment can start when they begin to have symptoms. So not getting cancer treatment right away is called watchful waiting. Now, chemotherapy. Chemotherapy, this is basically the medication that is usually given, to these patients who have leukemia. So people with acute leukemia need to be treated right away because it is very aggressive, and secondly, their survival rate would be very, very small if they are not treated, so they need to be treated right away, So the goal of treatment here is to create remission, and also to prevent relapse, What do we mean by remission? Remission basically means that stage whereby the signs and symptoms have gone away, So the goal of treatment is to destroy the signs of leukemia in the body and make the symptoms go away, what we refer to as the state of remission. And then, when after the patient is in remission, then you want to prevent relapse. So basically, that is how chemotherapy is given. And then there are 3 phases of chemotherapy. There's what we call the induction phase, whereby in the induction phase, the usual criteria for complete remission are when there are 55% of the bone marrow cells and normal peripheral counts, So basically, that is what happens. You give this medication, to attain about 5% of the normal bone marrow cells, and then also having the normal peripheral blood cell counts, all the blood cells, So once you're doing that, you're basically you're into what we call the induction phase, and basically, as you're doing this induction, you expect to have remission, You expect to have remission. In other words, you expect the signs and symptoms to go away, Now, when this has happened, then you start the other phase of what we refer to as consolidation, So here, basically, it is intensive chemotherapy, It's basically given to eradicate any remaining disease, And usually here we give a higher dose, a higher dose of the chemotherapy and can be administered. And usually they combine, these agents, to get better results, And then after the consolidation, then the maintenance phase, whereby here smaller doses of different combinations of these medications are given to maintain the patient so that they do not relapse. Right? There's what we call targeted therapy. Basically, targeted therapy, you want to target the actual cells and spare, the normal cells, and hence you're decreasing, the toxicities and you're also decreasing the adverse effects of these medications. So drugs like ozofamacin, these are basically given, and they are more, more specific and help in targeted therapy. Then the other one, especially with remember we said with the chronic myelocytic leukemia, usually the cure, the cure is basically stem cell transplant, So you need a transplant, you need transplant. And I don't know whether you did this, you're going to do this in palliative care, but But when we say transplant, usually it is basically divided into three, as we are going to see. Yeah. So that transplant, it's like you're getting cells from either yourself or what we call autologous, or from a compatible donor. Yeah. So and so when you get these are basically put into the bone marrow, and then they regenerate, and then you become free from, you can then totally eliminate the leukemic cells. Yeah. So to totally eliminate the leukemic cells from the body, you use a combination of chemotherapy with or without radiation. Then it eradicates patients' hematopoietic cells, yeah, and then replaced with a human with what we call the matched human leukocyte antigen, yeah. So basically, before you undergo stem cell, they have to first give you chemotherapy to make sure that they kill all those, and then sometimes they also do radiation before they give you the hematopoietic stem cells from a relevant donor, yeah, either from you yourself or a sibling, or so who can donate? Who can be the donor? It can be a sibling. It can be a volunteer. It can be an identical twin, or the patient's stem cells removed before they got to the condition. Yeah. So those are the people who can basically donate the transplant. So there's what we call allogeneic. There is what we call autologous, and there are allogeneic and autologous. So with allogeneic, they basically want that human leukocyte antigen from either from a donor, from a suitable donor, yeah, from a suitable donor, and we say that can be a sibling, yeah, or it can be a volunteer, yeah, it can be a sibling or a volunteer, yeah. So yeah, basically right match, the patient undergoes this test, the human leukocyte antigen test, and through this test we compare the patient's blood and tissue type against the samples from the donor. Yeah? So donors may include a sibling, an unrelated donor, a mismatched family member, or an unrelated umbilical cord blood. So these allogenic donors may be those. Yeah? And then we have autologous. This is basically these are basically collected from the patient's heme or herself. Yeah? All right, and then basically that is it about stem cell, yeah, stem cell transplant. Yeah? And by the way, these things are done in developed countries. Like for example, I know of a lady. She had 2 sicklers, yeah, and unfortunately, that lady is here in Uganda. That they are basically well to do. So one sickler was successfully done a bone marrow transplant, yeah, and that sickler that so-called sickler is no longer a sickler, yeah, because the condition does no longer has. However, the other one, when was done a bone marrow transplant, it was not successful, yeah? And it's still a sickler. They want to do it again, yeah. So these things actually work, yeah. However, they are expensive, yeah. They work, but they are expensive. So you don't want to pray to have any of these conditions, right? So nutrition and physical activity, of course, these are very important, yeah, in these patients. Yeah? Follow-up care, regular checkups are also very important for these patients. Yeah. Now, as far as nursing management is concerned, What are some of the diagnoses? Impaired oral mucous membrane, ineffective therapeutic management, imbalanced nutrition, and risk for injury. Yeah, so these are some of the nursing diagnosis. Then the goals basically understand and cooperate with the treatment plan, experience minimal side effects, feel hope, and all those things. So rehabilitation, physical, psychosocial, spiritual, and all those things are very, very important, yeah, as far as the management of these patients. So, ladies and gentlemen, that has been a brief, or you can call it a big presentation about leukemias and proliferation of white blood cells. Yeah, we started with this big topic, and we subdivided into small topics. And so we have just concluded the topic on leukemias. Yeah, and so I hope you understand. Please make note. Make note, and maybe I said this at the end, but make sure you watch this video to the end. Yeah, and of course we are nearing towards the end. Yeah, I should have said this at the beginning, but make notes. Make sure I understand these things, and if you do not understand some of these things, do not hesitate to contact me on my WhatsApp or on my email. Yeah, so that we can clarify some of these things. As I said earlier on, I repeat, some of these topics will be discussed by you. All right. So thank you so much. We have looked at the proliferative disorders of red blood cells, and we have just concluded with leukemias. Our next presentation will be lymphomas. Ladies and gentlemen, at this point, I want to stop this recording so that we can do other things. Thank you.